Hi, everybody. My name is Saira Kalia. I'm an associate professor of psychiatry, and I'm the director for the Arizona Perinatal Psychiatry Access Line. And I'll be talking to you today about general principles in the practice of reproductive psychiatry. So, a few of the key things to keep in mind that are always important is contraception and expect pregnancy, right? So ask every person of childbearing potential about contraception. About 50% of pregnancies are unplanned, and when you take that subpopulation of birthing persons or women with psychiatric illnesses, that number shoots up to about 70 to 80%. So in that subpopulation, unplanned pregnancies are pretty common. So it's very important to kind of talk about contraception, their reproductive status, planning for pregnancy, and kind of discussing the reproductive potential of meds is really important. Discuss early. So even if this says somebody that says, no, I have no intentions, no plan to get pregnant, this is not on my radar for the next few years, still have the discussion, make sure that they're aware of the reproductive risks and the risks of pregnancy to their mental state, as well as, of course, risks of medication. When to screen for mental health issues. This is at an initial prenatal visit to identify if there was any antenatal issues. And of course, during the pregnancy and during the postpartum visits as well. This is for any frontline providers, OB providers. So keeping that in mind, getting a mental health history when you can, and keeping that on your to-do list, if you will. You can use a variety of screeners depending on where the patient is in their reproductive journey. PHQ-9, GAD-7 are well-known, validated screening tools for depression and anxiety. If you are considering incorporating a screening tool postpartum, you could consider the APDSS, which has postpartum anxiety. It's a slightly longer consideration. So if you can only use one in the postpartum period, I would consider the APDSS. If you do have PHQ-9s and GAD-7s already incorporated, that's great as well. Just keep in mind that sometimes they're not that great in terms of the postpartum considerations because they highly weight things like sleep, which, I don't know people who have great postpartum sleep regardless of depression or anxiety. In the scenario that you are discussing the risk in pregnancy for their medication, the discussion is not risk versus benefit, it's risk versus risk. And the reason is because there is risk of disease. So untreated disease comes with its own risk. And of course, medication or treatment comes with its risk as well. So keeping in mind that you're not doing a discussion scenario where you're saying, if you do take treatment, this is all the risks of the treatment, that you are balancing that out with, if you do not go with treatment, the risks of relapse, depending on what your disease is X, Y, and Z. And then, of course, the risk of disease are things to keep in mind. And things to keep in mind in terms of untreated psychiatric illnesses and the risks as well depends, of course, on the disease that we're talking about. But if you're thinking about, say, perinatal depression, high rates of untreated depression is associated with high rates of preterm birth, low birth weight, problems with attachment and bounding. This is data that we've had since the 70s. Increased rates of psychiatric disorders in childhood and adolescence. And then, of course, perinatal bipolar disorder, high risk of mood relapse. So this could be a depressive state, this could be mania, this could be hypomania. Suicide is a high risk, antepartum hemorrhage, placental abnormalities, preterm birth, low birth weight, microcephaly, neonatal hypoglycemia. So a whole host of consequences from a maternal mental health perspective, gestational outcomes, as well as neonatal outcomes that you have to keep in mind. And then untreated perinatal anxiety, decreased placental blood flow, risk of higher rates of preeclampsia, gestational hypertension, preterm birth, low birth weight, prolonged labor, impaired attachment. So kind of a whole host of problems as well, both for the mom and the neonate and, of course, the child's mental health as well. Untreated perinatal ADHD, we wanted to bring some attention to that because I think people have this very much like, oh, if you just will through it and suffer, it'll be okay. Like ADHD is not a disease worth treating or doesn't require treatment, and it's just a indulgent choice. And so in pregnancy, you don't indulge yourself, kind of a deal. And untreated ADHD, severe ADHD, is associated with things like miscarriage, preterm birth, NICU admissions, poor maternal nutrition, decreased prenatal vitamins, increased stress, and of course risk of car accidents. So when you're thinking about taking care of a patient in that reproductive time period and they're on psychiatric medication, do not stop all meds just because someone is pregnant. Look up their risks, unless of course it's difficult, then stop. look up the risk of the medication on reprotox, on infant risk, on mother to baby, or just call us, the Arizona Perinatal Psychiatry Access Line, and we can kind of help you navigate the risks of the medication. And if the person is already is not on medication and you feel like medications are not indicated, think about optimizing that non-medication options. So these are things like supplements and light therapy and therapy itself and support groups, and increasing sort of the network as well. So a lot of the times people will respond to non-pharmacological treatment options, except those have to be included and brought in as part of the care, and not just said, oh yeah, think about all of that. Have to almost prescribe, if you will, exercise. And then if you are dealing with a patient who is on medication, they choose to stay on medication, treat to remission. And this is a big one. People treat the depression and they're like, oh, you feel better? Great. That is not the goal. Better is not the only goal. The goal is remission, because you do not want to have the dual exposure of disease and medication. That's just not fair. Then you're just stacking the two together. So treat to remission, that is the goal of the treatment, and is always the goal of the treatment. So go for that idea. Do not go with, oh, well, you feel better and we want to keep the doses low. That's not the goal. Or people that are on Depakote, stop it immediately during pregnancy and do not use it. Folic acid for everybody that's on a second generation antipsychotic. And if you're going to start antidepressants, please screen for bipolar disorder. If the patient is already pregnant and meds are working, be careful about the impulse to switch to a best option in pregnancy med. The goal is to make sure that the patient is on the medication treatment that works for them and you're avoiding relapse. Something to keep in mind when you're talking about perinatal mental health, reminding the patient that they're not alone. Psychiatric illness is very common. Perinatal mood and anxiety disorders alone recur in 1 in 5 postpartum women, and this is why we screen during pregnancy and postpartum. There are medical conditions that deserve to be treated, and they do not occur because of a failure on your part, like you didn't do something or you did do something and therefore you're in this scenario. And of course these treatments are treatable and people do respond to treatment and get better, and so we can kind of avoid a lot of chaos for families, for babies, for communities, for moms, for relationships, if we just approach them the way we would approach medical conditions. And treating psychiatric illness does improve outcomes for moms and babies. If you are a provider and you're like, I would like to learn more, you can contact us with the Arizona Perinatal Psychiatry Access Line. Our number is 888-290-1336. We will provide real-time psychiatric consultation for your reproductive age patients. And of course, you can request trainings. So we will come in and provide trainings for your practice, and we might come in virtually, but we will come. And these are our references, and please let us know if there's anything else that you'd like to learn. Take care. Bye.